Good evening and welcome to the discussion about bioidentical hormone therapy. I know that a number of speakers prior have spoken on hormones. I'll try to give a little bit different perspective. And I want to begin, though, by asking how many are actually on hormones right now? How many are considering it or want to know for somebody else? Okay. So a fair number of people here are already on hormones. And I want to stress, too, I am interested in your questions. It's going to be hard in a way not to personalize. So maybe say, I have a friend who, that type of thing. But because hormones are kind of personal, aren't they? We take them for a whole variety of reasons. And I just want to stress, your questions are the best I've ever experienced. I'm always in awe of audiences that come here from Tahoma Clinic because you know your stuff, and it keeps me on track with my stuff. So I want to point out one thing in your packet. You have perhaps a formidable looking chart here. This is the hormone pathway. It should be at the very end. I believe that, yeah. I'm going to refer to this periodically. And I speak of when folks come in to see me about hormones, I speak of hormone graduate school. So after people learn the basics, then we start to work with the chart. We work with amounts of hormones and so on to get you to the optimum dose for you. That doesn't mean that we miss it. I'd say 90% of the time we hit it right on. But occasionally then we have to adjust. Depends when in the life cycle that a person goes on hormones to. Earlier on, let's say a woman before menopause, her hormones may continue to drop even if she's gone on hormones. For men, because there's no definitive menopause like there is in women, there's andropause. We don't always know when that kicks in. But we have a saying, it's Dr. Wright's saying, I'll just say it. You know, the grumpy old grandpa? That's maybe a guy who needs testosterone. So it can affect mood. So I'm not saying about anybody's spouse or friend or grandfather, but anyway, that can be an indication of needing hormones. So I'll refer to this from time to time, but I want you to note, and I'll mention it later on, everything comes from cholesterol. Cholesterol is a steroid, so in essence, we are all on steroids. So the mass hysteria about steroids is just that. I actually happen to believe that people who are out there doing athletics, you know, to keep up, they may actually need some of these things. So anyway, I'm not advocating for things going on in sports, but just to say, to keep up our endurance, sometimes adding these things are very important to overall health. I want to mention, too, that 3 books I like very much. There are dozens and dozens. But we've all heard about, many people have come in based on Suzanne Summers' work in Breakthrough. She does interview Dr. Wright very early on in the book. And she's about to, I think, in a couple of months, have a new book out as well on that. Now, Dr. Wright also he's got a number of books, but his latest one is called Stay Young and Sexy. And I will say, with apologies to the men, there's one chapter in here on male hormones. It's just one. But luckily, Abraham Morgentaler of Harvard, I'm supposed to mention Harvard is respectable, so they're talking about hormones, testosterone for life. It does cover it in much more depth. But in general, everything Dr. Wright says is applicable mostly to men and women about the safety of the hormones, dosing them, using them, things like that. So those are several books that you can look into. I think we have all 3 next door in the dispensary. So I put together kind of a basic outline, and because I thought that a lot of things would come from your questions as well. I want to personalize it a little bit in the sense of, you know, I know about, I've heard this, that type of thing. So where did bioidentical hormone therapy begin? And I'm going to say it actually began, not that he invented hormones, but he invented the bioidentical approach to treatment with hormones, and that's Dr. Wright. So He is the father of modern bioidentical hormone therapy. Now, he did not invent Premarin. He did not invent those types of things. But what happened in the early 1980s, a woman came in who said, I'm interested in having you treat me for hormone replacement therapy, which had been going on for quite a while. And he said, okay, and he started to prescribe her Premarin and those types of things that were very common. Now, just to clarify, Premarin is manufactured from pregnant mare's urine. That's the derivation of the name, Premarin, pregnant mare's urine. It is not biologically bioidentical, and it doesn't act the same in the body. And so he started to write that, and she said, excuse me, but I'm not a horse. I want something bioidentical. And it didn't exist at the time. It literally didn't exist. And Dr. Wright, as many of you may know from his newsletters, other things, he actually speaks about copying nature. So this actually, it caused him to start thinking about hormone therapy and what it was that he needed to do in order to prescribe hormones appropriately to copy nature. So he actually worked with a gentleman by the name of Ed Thorpe up in Vancouver, British Columbia, to develop a product called Triest. Triest is 3 estrogens, estrone, estradiol, and estriol. Later on, they developed a product called Biest, and I'll go more into this. But so they developed this, and they basically then started to look for ways to actually monitor and test. And Dr. Wright's developed a comprehensive hormone profile using urine that is used to test for the hormone metabolites, things that affect our ability to use the hormones. Does that make sense so far? Okay. You see Tawny came in behind there. Keep me honest if I go off track here. Okay. So what are the hormones that we're talking about? And I mentioned this earlier. We're all on steroids, basically. These are hormones, and I'm specifically talking about things related to this particular pathway. There are other things like thyroid hormone, other things that we can apply and benefit from, but I'm specifically talking about these. So they're derived from cholesterol. I've actually had some patients come in with cholesterol levels so low, and with deference to cardiologists who want these numbers as low as possible, I've seen people come in with some numbers so low they're not producing hormones very well. It used to be that when cholesterol levels were that low, we went looking for cancer as an underlying cause, an underlying factor. And so you need a certain level of cholesterol in order to produce steroid hormones. In women before menopause, the hormones are produced by the ovaries. We have 2. I have seen many women, and maybe it's the folks that come here, but I see a lot of cases of early ovarian failure of hormones occurring in even the 20s, 30s, and 40s. Well below this should happen. What menopause is, as women in the room know, is it's a lowering of those particular hormone levels to the point that you no longer have a menstrual cycle. Usually the definition of menopause is 12 months, no cycles. That will define menopause. After menopause, then you're producing hormones only from the adrenal glands. Some adipose tissue will contribute, but primarily in women from the adrenal glands. In men, most hormones are produced by the testes, and some also from the adrenal glands. So they're not going to experience the same type of thing like ovarian failure, but there are other complications that can occur with hormones. Any questions? Okay. So what we're talking about is bioidentical hormones. Just like the horse urine is not comparable in terms of the hormones produced. It's not comparable to our own hormone makeup. But bioidentical means biologically identical. They're derived from the Mexican yam, and this is all of these that I'm going to speak of. And they are, then there's a little bit of a synthesis needed in order to take it from the yam in order to make it biologically active within the body. Then, and I was saying in this clinic, we primarily give hormones that are taken on through the skin or transdermally or through the mucosa, transmucosally. For a woman, this means through the labia. For a man, it usually means the rectal mucosa. There are other ways to use hormones, though. If that doesn't appeal, it doesn't work. Sometimes people become more sensitive. So it can be applied in different ways. We don't, in this clinic, though, give oral estrogen of any kind. And if a practitioner has given you or suggested oral estrogen, I want you to think about it. Think about it twice. Because studies have shown it does increase the risk of blood clotting within the body. So the thromboses that can be created, we talk about this with birth control pills, for example, that early in life that this can contribute to blood clotting and other risk factors. Well, the same is true of taking oral estrogen of any kind. So want to stress through the skin, through the mucosa, is the safest way to go. What happens when you take it through the skin or through the mucosa, it reduces the risk of metabolites being formed as they pass through the liver. We call it the first pass effect. The metabolites are formed, and that's what is on here. You have a lot of things you don't know about yet, that are formed as the hormones pass through the liver, and it is passing through the liver where they're gotten ready to be excreted from the body, but in the process they can be detrimental to the body itself. Does that make sense? I'm going to go over this a little bit more. So, yes. So the question is about the Mexican yam. Is there something unique about it? I thought that question might come up, and I'm not sure how they developed it from Mexican yam. Probably the way many other drugs are developed as well. For example, I'll give you an example. Have we heard of red yeast rice? Okay, red yeast rice is actually the component, the same thing as a statin, but in a natural form. So when they developed statins, they developed it out of the components found in red yeast rice. Very same thing with other natural products. There's usually a plant or an organism of origin way back when, before it got turned into what Dr. Wright calls a space-age molecule, something not normally found in nature. You cannot patent something found in nature. So the Mexican yam, they found that they could convert it directly into biologically active hormones that were biologically identical. The yam has been used for many, many years in topical creams, that type of thing. But it's only in recent years that it's been used as a hormone. And I can find out more about that. I knew it would come up, I just didn't remember the origin. Okay. So in other words, what I've started to say is they're safer. They're safer than other forms of hormone replacement. So the types that are used, we have estrogen in the form of estradiol. Estradiol, or we would call E2, that's the estrogen of our younger years as women. Men also have estradiol as well. Everything I'm going to mention, we all have. It's the amounts that we have that differentiate who we are sexually. So that's really key. It's really key that we come from the same origin and then we differentiate. The estradiol is in higher amounts when we're younger. I speak of that as the hormone of conception, the hormone that probably contributes to a greater sense of libido, that type of thing, although the androgens define libido. Estriol is one of the more anti-cancer hormones, and that both of those comprise the compound biest. And when we speak of biest, think of it two ways. Bi and est. Bi means two estrogens, estradiol, estriol. And I also will put it this way, biologically identical estrogen. So the biologically identical estrogen or biest. Triest is a form of estrogen replacement, very similar, and it's the one that Dr. Wright and Ed Thorpe started out using, and they use it for a long time, and there are still some women who are on Triest. Triest is estrone, estradiol, and estriol. So E1, E2, E3. I don't expect you to remember all of that, but you might hear it in conversation, and so it's useful to know what that means. We don't use it as much because in women who are in menopause, estrone is produced in higher amounts than the other two, unless we actually add it in. So especially if there's a significant adipose tissue or fat tissue, you'll produce more estrone. Progesterone, actually let me show you on the pathway. There will not be a test later, but so when we're talking about cholesterol, we're starting way up here, and then we'll talk about pregnenolone a little bit later, but progesterone is almost the master hormone. Pregnenolone we consider the master hormone because it can go everywhere in the body. We don't exactly know where it goes, but my observations are in giving it to women that it literally goes where it's needed. So one of the important facets of bioidentical hormone replacement is 24-hour urine testing. So we'll do a lot of hormone testing to make sure that what we're giving is in the right amounts. So progesterone actually can go a number of different ways, and it'll often flow down and help support DHEA and testosterone. And it also, we use it in an important way in terms of sleep support in the body that I'll get to a little bit later on. Testosterone is one of the male androgens. Women, we also have it too. And then in terms of libido, two most important questions I get asked when people come in. Can you fix my hair loss? And I have no libido. Can you fix that? So we're talking about testosterone and DHEA for supporting libido and for both men and women. So testosterone is the hormone that defines men, who they are, the hair, stature, muscles, libido. DHEA is also an important androgen. It acts a little bit differently. We think of it a lot like an adrenal hormone. And it has important benefits in terms of bone health, in supporting libido. It's the primary libido hormone in women. In terms of providing it, though, I don't always get the result that I want. So clearly it's a combination of testosterone, DHEA for women. Pregnenolone, I mentioned, is the master hormone. And growth hormone is not on this. It really is a hormone that is produced in highest amounts during sleep, promoted by melatonin. And, or the fact that you are sleeping producing melatonin, then you're more than likely producing growth hormone. Questions so far? Yes, ma'am. So the question is, if you have trouble sleeping, then your body may not produce as much melatonin. Yes, you may not produce as much melatonin and not as much growth hormone. So it has important implications, especially folks that are shift workers, that type of thing. So progesterone is an important support for sleep, and I'll talk about that a little bit later. So I hear this all the time too. What holds people back from doing hormones is the question, is it safe? And my answer always begins, there isn't anything safe in the world. I can't guarantee it. I try to consult my crystal ball every time I sit down, but I can't tell you. Having said that, having been here for a while, I have yet, knock on wood, to see a problem developed. with hormone application that is done right. I've seen people experience concern, but at the same time when we tested and evaluated, we did not find anything that was there. A person can get into trouble, though, with bioidentical hormones if they decide that they're going to raise their levels on their own. They decide they want our hormones to act like something called the Wiley protocol, which is a stepped amount. You step it up and then step it down with the cycles. So if you don't follow the recommendations of the practitioner, you can get yourself into trouble. And that's where we do recommend regular follow-up testing. The primary way that I like to test, and it depends when a person comes in and what's going on, we like to test with 24-hour urinary profiles. And that gives us literally about everything on this piece of paper. It's quite an incredible test, and it gives your practitioner feedback on what's going on in the body with regard to the hormone. I will do blood testing in some cases too, especially in certain circumstances with men, for example, where I'm testing PSA and I want to look at the free and total testosterone. So it's very important to assess what's going on. I feel that when we give these hormones here, we're giving them in low enough dose, and then we're monitoring, and we're giving only enough to quell symptoms, and they stay safe. And we're watching every other parameter, not giving estrogen orally, making sure the numbers stay in range, and also finding out how you feel. It's how you feel that helps determine whether this is a good dose as well. I've heard people come in and tell me they've gone elsewhere conventionally, and many of those folks are, they give you one dose, here, take this, you'll be on this a year, and then you'll be done. It's not a one-stop shopping here. It's applied to you personally, and each practitioner would say the same thing, and I believe that's how hormones should actually be given. Does that make sense? And we're also avoiding the first pass effect through the liver itself, which reduces the production of negative metabolites. So what are the benefits? Why do people come in? And a couple of years back, when Suzanne Summers, put out the book Breakthrough, and she was on Oprah, and Dr. Phil's wife got her book out there. Then we were overrun. Everyone wanted to be on hormones. So it's an individual choice. And I'll say one of the most compelling reasons for being on hormones to me is quality of life. And from what I've done, the research I've done is preventing dementia. Keeping the brain functioning properly is a very good reason to consider hormones. But if we think in terms of anti-aging, we want to keep age back. A lot of people come in and they say, I don't know when this happened, but I feel old today, or I feel like I'm aging too rapidly. So hormones do help improve the skin tone and texture. They do also affect dry skin, dry hair. They improve that considerably. One thing to think about, though, is many of the symptoms of low estrogen, they look like low thyroid as well. So it's important to look at both of those and see which one is actually low. Bone health, definitely after menopause, and also andropause for men, osteoporosis prevention is important. And I've seen when the hormones drop, bone density will also drop. Prevention of stroke and cardiovascular risk. If you think about the heart, the blood vessels as muscles, the hormones, especially testosterone, have a lot to do with flexibility and elasticity of those vessels themselves. Increased strength and endurance, that's key. And testosterone will often bring that back for both men and women. I see increased ability to exercise, increased ability to go through your day, and it also helps with balance. Yes, ma'am.
Does it help with actual tissue repair? Say you hold a hamstring or something, when you're exercising, you go who are on testosterone, would it help facilitate, is this an anabolic steroid?
Well, the question is would taking testosterone help with healing? And I've actually recommended it in some cases, particularly for that. It's more complex. When you're looking at healing, you're looking at things that affect not only hormones, but do they have adequate levels of vitamin A and zinc, vitamin C? Are there any toxicities that are interfering? Is growth hormone perhaps low? So growth hormone can particularly help with healing, but yes, if this is low, or you have not, you've tried all those things and nothing is working, then testosterone can definitely help. It does increase stamina and strength, so I have tried it with folks, and I do suggest it as well. And hormones actually also help with sleep, particularly in women. I have not tested this out in men. Most men don't come in and say, I'm not sleeping. It's not a common complaint that I hear, but I'll bet you it's maybe almost as frequent as women. So we'll see. I'll start asking that question more. Yes? So the question is, if somebody is approaching menopause, which means in essence someone is still having cycles, and then hormones were to be given, would that basically prevent her from going into menopause? It's a complex question because that time, perimenopause, that you're talking about, it can range anywhere from 5 to 15 years before menopause starts. So in your 30s, you can end up with these types of problems starting. That's a tricky time. And let me tell you a strategy that I use for that. So I'm going to back up to the testing for a minute. If a woman comes in menopause, and I know she has not had cycles for many months, at least 12 months, I don't need to measure her hormones at that time. I know that estrogen and progesterone are not there. She's not having cycles. They're primarily the reasons why menses occur. But in the case you're describing, perimenopause, I don't know the levels. I don't know where you are. If you're still having cycles, then I know you have some degree of estrogen and progesterone present. To determine whether fertility is still there, whether you are actually in menopause, you'd want to measure a couple of things, FSH and LH levels. They will shift when you're actually in menopause. But in that period of time, we're going to measure the hormones, see where you are in terms of actual hormone levels, and treat accordingly. Oftentimes, progesterone is given because many women are low in that. I give estrogen. Sometimes it depends on the symptoms. So, complex questions. So what happens then is the women's hormones are actually going to continue to drop until the ovaries stop producing them. The adrenals take over at a very low level. So I will sometimes give hormones, sometimes not. But what starts to happen that makes it uncomfortable is hot flashes, night sweats, dry skin, dry hair, low libido, the whole gamut of symptoms. So if we start to give some hormones to help support that or treat by supporting your normal levels, I find that sometimes menopause will be less extreme. What we try to give hormones to the level where we're not causing breakthrough bleeding or menses. That's not desirable. So it's a balancing act. So sometimes women will have to come in periodically because their own hormone levels are dropping. Then we raise the other levels up. It's not like you don't go through menopause. We just don't know the exact date it occurred. We can measure it in other ways with the FSH, LH levels. We can see, but do you actually experience 12 months of not having a cycle? That's where it's tricky. And I know it's complex. It's hard to explain. Okay.
Somebody's like adrenal exhausted, and you said when you go into menopause, that's what's supporting, right? Adrenal, what's supporting the hormone, so maybe that's not.
Well, so the question is if you're in adrenal exhaustion and you go into menopause and those hormones are what are supporting you, not quite the same. Adrenal exhaustion is more related to the output of cortisone and cortisol, not necessarily related to those hormones. They're going to be low anyway, so when we measure on the 24-hour urine, we can get a baseline level of those. I wouldn't put those in the same category, but we would if you're in adrenal exhaustion, we would support those, and DHEA and testosterone and progesterone can actually help. So I'll use those sometimes to support adrenals. I'm getting kind of complex here. Yes, ma'am.
Giving somebody bioidentical hormones in perimenopause is not going to stop them from losing their fertility. You know, it's not going to maintain their fertility. Regardless.
So the question is, if giving hormones in perimenopause will maintain their fertility? The answer to it is it depends. It depends. What age they are, where they are in terms of their fertility. Are they already an ovarian failure? If so, it's not going to turn that around. But I know fertility clinics will still try to support hormone levels. Two of the most key things to try initially for that situation are vitamin D, 10,000 IUs, both for the man and the woman, and DHEA. Those have been reported to help with fertility. But if your own level, if you can't support those levels, then no, it's probably not going to lead to fertility. I haven't had anybody come back and say, oh, you get, except, I'll go into that in a minute. I haven't had anybody come back and say, I conceived a baby because I went on bioidentical hormones. I have not. I do know someone of childbearing age who experienced low hormone effects, gave herself progesterone, and oh, by the way, did get pregnant. So it can happen, but she was a much younger age. So you do have to be careful, but if your hormone levels are already dropping, I don't usually see it come back. There was another question too. Yes, sir.
Improve sleep, is there best time to apply?
Oh, okay. So for improving sleep, the question was these improve sleep. I usually use, in women, we'll use progesterone, but improving sleep, apply it at night before going to bed. I've had testosterone also help with sleep in some people, men and women. But as I said, most men don't bring this to me as a complaint. I don't hear it. Maybe I should quiz them more. But yes, sir. Okay.
I just wondered about foods, when it started. It was feeling more emotional.
Okay. So the question is a friend who just went on estrogen and is feeling more emotional, not less. I guess the question would be, what was the balance? Was estrogen given? Was progesterone given? Was testosterone given? What would be the balance? I've seen some people come in that they're on estrogen or they're not on estrogen and very weepy, and I've also seen this happen in men. Men can sometimes have very low testosterone, and this is what's the interesting thing that occurs. You want at least a 4-to-1 relationship between estrogen and testosterone in men, so they need to have 4 times as much testosterone. If that shifts and they have more estrogen than testosterone, I've seen men come in very emotional, be more weepy, that type of thing. So I think it goes back to the balance of the hormones. Is this person on the right balance of hormones? What else is going on in that situation? I think it's maybe a matter of titration, of adjusting the dose. So let me go to the next slide for a second. So we've talked a lot about this already. When are hormones prescribed? For women, hot flashes control. So in the case of the perimenopausal woman, and even in menopause and postmenopause, you see hot flashes or flushes. They'll often refer to it as flushes. Night sweats, those are the things that occur at night. The sleeplessness, and they often occur together. What happens to disrupt sleep is that the body will start to warm up. You won't feel it occurring until you're awake, and then usually aware you've got to go to the bathroom, right? Isn't that how that works? But what's happened is that there's been a dysregulation deeper in the body. And so when estrogen and progesterone drop, they actually also have an effect on serotonin at the level of the hypothalamus. The serotonin levels also drop. So when serotonin becomes dysregulated, then it will affect the vasomotor response, your thermostat, the thing that controls your temperature. And so during sleep, as those levels become dysregulated, you'll get warmer, wake up, be aware you've got to go to the bathroom, but not necessarily aware of what woke you up. So I find giving progesterone at night, along with helping with sleep, will help with this vasomotor response too. You can often get take away night sweats using that. Yes, ma'am.
If your serotonin levels are going down, is there anything that could raise that? I mean, that would be helpful in sleeping, wouldn't it?
Yes. So the question is, if serotonin levels are dropping, what could raise it? And this is an interesting thing. It's often the time when women get put on antidepressants. Men too. I see it more in women. That because there'll be mood swings, there'll be depression developing, and it's easy. Okay, we'll just give you an antidepressant. This will raise your serotonin levels, when in fact giving estrogen and progesterone will do the very same thing. But you can also use things like SAMe, 5-HTP, tryptophan, and I think those are the primary ones. You can take those in order to help support serotonin levels in the brain, and by the way, then they do also help with sleep. So the only problem is if you get put on an antidepressant and it's of an SSRI type, serotonin selective reuptake inhibitor, you cannot take those because it'll contribute to serotonin syndrome. So it's complex. I like to get to people before they go on these antidepressants because they change brain chemistry. And so if you get on these, and it's tricky, I've tried to bring people down off antidepressants, bring them up on hormones, and it's not always effective. So it's complex. I say this a lot to people. The knee bone is in fact connected to the thigh bone. It's all a circle overlapping effects. Yes, ma'am. The question is, does St. John's wort support serotonin? I know St. John's wort is good for mild to moderate depression, not severe. It should be. Tawny, do you know? Does it also raise serotonin? You don't? Oh, okay. So it does. It's good for mild to moderate, and I do believe you're supposed to be careful of that with SSRIs as well, not take too much, so probably has a similar effect. I can check that as well. Serotonin, that's the antidepressant types, SSRI. Okay. Yes, ma'am, over here. Five HTP, because they're precursors to the production of serotonin. Not SAMe so much, but 5-HTP and tryptophan, D-L-phenylalanine, all three of those are useful. They can raise serotonin, and the antidepressant is already raising serotonin at the synaptic cleft. So you don't want too much because that creates a syndrome related to overdose of serotonin. It's too much serotonin being present in the area where the neurotransmitters are, and so it can cause problems related to, well, agitation, that type of thing. The opposite of what you'd want to happen can occur with that. So it's basically like an overdose of serotonin. It doesn't happen very commonly. that I've heard of. We just as practitioners are very careful with it. And you don't want to also impact the effectiveness of the antidepressant. And it can have an impact on that. Yes, Bridget?
If you were with being on the SSRIs, and if you did the 24-hour urine test, would that affect that, or would they show up and say, oh, they'd say, oh, those are here, but you also, or is it like there'd be two almost diagnosed, that there'd be the SRIs show up,
Okay, well,
and whatever the 24-hour urine, you see what I'm saying?
sure. The question is would being on an antidepressant affect the 24-hour urine collection? Not really. It's not going to show us anything related to a space-age molecule, basically. It's not going to show me anything except the natural. When we're talking about collecting things through the urine, by the way, I want to differentiate the two. Things that are in the blood and measured in the blood, those are bound. There's a carrier in the blood. So albumin, other things that actually carry that molecule in the blood, they need an escort. Whereas in the urine, what we're measuring is free, unbound hormone. So there's nothing else that's along with it, and we're only seeing the natural. We're not seeing synthetic. If you were taking, though, a birth control pill, a synthetic, it can actually suppress what we see in terms of the natural compound. I can't see the synthetic and the natural. So that's where it gets a little bit tricky, but not in the antidepressant itself. Does that make sense?
Yeah.
Okay. And I'm not measuring serotonin in the urine anyway. What I know is when estrogen and progesterone are low, the odds are serotonin is also low. They don't know the mechanism, or at least I'm unaware of any new research into the mechanism. But it's key because years ago, women were even institutionalized for having hormone menopausal symptoms, things that look like depression. So we've come a long way in terms of understanding. There are just parts of evaluation that are lagging, I feel. Incontinence, too, is a big key in terms of hormone imbalances. Frequent urinary tract infections, if you know someone having those, that's often a laxity of the tissue itself. Estrogen, progesterone, testosterone help strengthen the tissue and help support it there so that if there isn't any urinary retention there that can create a bacterial haven. For men will notice testosterone levels. I mentioned the grumpy grandpa earlier. So they're not always the first one to notice the mood shift, though. Usually it's people that are around them that'll notice that. But men will notice reduced stamina, reduced exercise strength, reduced muscle mass, sometimes balance issues, low libido, big key, erectile dysfunction too, we'll see that. BPH, benign prostatic hyperplasia, problems urinating, that type of thing. Other symptoms that are indicative of low testosterone. I know it's kind of popular these days to speak of low T out there. We've been talking about low T for many decades in the sense here. But there's a lot being written about it, a lot of questions, particularly as they pertain to prostate cancer. So I mentioned the reasons why hormones are prescribed. They're also prescribed in women who have what's known as polycystic ovarian syndrome, which is an imbalance in the levels of their hormones and testosterone. So we'll give things like progesterone for that. Early ovarian failure, again, I've had women come in as young as 20 having had a hysterectomy. So imagine spending most of your adult life without, and this is a complete hysterectomy, so the ovaries are gone. Imagine spending most of that time without hormones. So it gets really tricky. And then again, to improve fertility. So what do we need in order to know whether you should take these or not? Now remember, we're really focused on safety. And I am, if somebody comes in and is on hormone therapy, I ask for testing at least once a year. But if a woman comes in and she's actually in menopause, no cycles for a year, then I don't have to test her then. I know that her hormones are already low. So I will do a trial of hormones for her. That might include just progesterone, it might include estrogen and progesterone, and it might include DHEA and testosterone. We do give progesterone here, even if a woman has had a hysterectomy, because of the receptors in the body that are sensitive to progesterone. It also is helpful in promoting sleep, reducing anxiety, helping support or reduce night sweats. So there's a lot of benefit for progesterone. We do also give progesterone to men because all of the hormones, estrogen, progesterone, testosterone, are anti-inflammatory. And what happens after menopause in many women is we get an increased amount of what we call autoimmune disorders. It's kind of unfair, but men get fewer autoimmune disorders, and they think that it's linked to the level of testosterone. So testosterone is also an anti-inflammatory hormone. We will give estriol, or E3, one of the hormones that's in Biest. We'll give it for conditions like MS, for example, in higher amounts because it seems to help with autoimmune conditions as well. So someone coming in with that type of an issue might be put on estriol. What we want to do with anyone coming in, though, is we want to make sure that there aren't any health risks. And this is where a personal history of cancer, family history of cancer is key. Do you have any clotting factor issues? Do you have any other health risks? For men, insulin resistance is a factor in terms of the ability to use testosterone. We'll measure a free and total PSA. And I know there's a lot of controversy about PSA. So what that stands for is prostate-specific antigen. But whether or not people consider it an important indicator of prostate cancer, it's still important to measure the velocity of change. So if a man is staying at the same level for years, we're less concerned than somebody who's going up by a point every year. So it's still that velocity of change that is key. So we measure PSA before and after going on the hormone, usually testosterone, DHEA. I didn't mention it here, but prostate health is key. We'll have you do a digital rectal exam. Many come in already having had that done through their primary care provider. And so we do these things to make sure that there's no risk of prostate cancer present. There's a lot of controversy about it, and Dr. Morgenthaler talks about it a lot in this book, so if that's a concern. But basically, we don't see an increased risk with giving testosterone, and the studies don't show it either. But we want to make sure we're not giving testosterone when somebody actually has a diagnosis of prostate cancer, so we don't give it at that particular time. But the evidence doesn't seem to show that it increases risk or that it makes it worse. Any questions on that? Yes, ma'am. So the question is, when we test testosterone or here, is it different than conventional? Not really. If we're talking blood or we're talking urine? Blood, okay. It should be comparable. In fact, one of the tests I really like a lot. So when we measure PSA, the free and total, again, free is that which is unbound, and then testosterone free and total. I like to do what we have, what's called an age management profile, because for the same price of the PSA and the testosterone, I can also get homocysteine, CRP, IGF-1, so I get a whole lot bigger bang for the buck. And so that's why I like that one for men. I'll often test blood initially, and then later on we'll test the urine and see where things are. So we've talked a lot about menopause and what happens. Some women will actually end up with a very abrupt stop. Someone will continue for a long period of time. And I went over the serotonin there as well. Are there questions related to why to give hormones in menopause or anyone? Yes, sir.
I wonder if you supplement a hormone, is that
So the question, and it's a good, very good question, is if in supplementing hormones do we see the body's inability to produce their own? When a woman is taking estrogen and progesterone, her production, and we're talking about she doesn't have any production essentially, that is not it's not going to suppress because the production's not there. There is some evidence in men that there can be a suppression of testosterone. Sometimes in terms of those that are being treated for fertility, they're not always told that it could suppress. It can suppress sperm production. It's a small amount, but it's relative. And so in that case, you would drop back the testosterone, but it can come back, cycle back, and suppress your own production. Hopefully, you're testing and monitoring and maintaining at a range that is you're not experiencing suppression. It would be if you're taking too much, for example, that you might experience that. Yes, sir. Mm-hmm. Mm-hmm. Okay. So the question is, taking some of the precursors. You mean can those be used? And you're speaking of the specific metabolic precursors, like we measure in the 24-hour urine. You mentioned the androstenedione. DHEA is actually also a precursor as well. But we will often suggest things like herbal remedies like tribulus or things like Propel, things that actually help with getting the effects of testosterone without actually being testosterone. Primarily, we'll use the things like DHEA, testosterone, sometimes progesterone to help with levels. I can't think of any other things that we do. We will sometimes, if we're addressing something related to DHT, let's say where BPH is a concern, we'll use something called 3-beta-A-diol. It's not actually a testosterone precursor, but it can help reduce that particular risk related to prostate cancer and BPH. But I'm not aware here where we're using those particular kinds of precursors. We keep it pretty simple. And I know Dr. Wright's philosophy on using them. He likes to dose them each individually, DHEA, testosterone, as opposed to mixing them. And we avoid a lot of things like injections and pellets, sipping to mostly the gels and the creams. I've had people come in on pellets, things like that, and sometimes their numbers stay elevated for a very long time. I like something that we can control and take away or add to within a very short period of time. But it's also individual. There are times when it might be more prudent to use something else on an individual basis. Does that help? Okay. Okay. Yes, ma'am. So the question is, do we use the testosterone patches? I have mixed feelings about the patches in general because I know there are, again, times when they're appropriate to use. There might be conditions where it's appropriate to use. But just like for example, the Vivel dot and other things that are dependent on delivering a specific dose, it's an uneven dose. It starts out high and then drops off, and then you add another one. Most of those are not, for women, for example, designed to be cyclic. And the other part of bioidentical that I didn't mention is we copy nature, as in a woman's cycle. So we believe in being on hormones 25 days out of the month, like the natural cycle, being off 3 to 5 days. In terms of testosterone delivery, we don't have that same issue for men, but then we still have an uneven dose in terms of when it's delivered. And I prefer something that we can control and measure as opposed to something I cannot. But I will say, just because I don't use it a lot doesn't mean other practitioners might, and they probably have good, strong reasons for it. Morgenthaler does cover the different types that are available, and I believe Dr. Wright does as well. These are all great questions, by the way. So I mentioned many of these things about women are vulnerable to antidepressants when their hormones are dropping. I don't mean vulnerable, I mean vulnerable to people putting them on them. And we primarily will do things in cream doses here. Progesterone is one of the exceptions that we can give as a capsule. In terms of the pathway, the oral, as I mentioned, go through different pathways to get to their destination. So sometimes we found for sleep that a capsule of progesterone can be more helpful to promoting sleep than the cream. I like to do a combination of both to get at both aspects of the pathway. And I just want to say, a lot of people are confused about this, but the hormones should be taken at different times of the day. Estrogen is a morning dose, unless there's a good reason to do it at night. DHEA is also a morning dose. It has a little bit of a neuroexcitatory component to it. It can be an adrenal stimulant, so that's taken in the morning. Testosterone is usually a morning. I know some men who may dose twice a day, but usually it's in the morning. Pregnenolone is the morning. Progesterone is at night. And so that's because of its effects on reducing cortisol. It competes with cortisol at receptors, and it can help promote sleep. It's more relaxing. I literally had a patient today totally confused about it, wondered why she was so exhausted during the day. So we switched, and so she's going to do progesterone at night, the estrogen in the morning, and see if she feels better. You can end up treating the wrong thing that way when people aren't taking it when they're most effective. Yes, ma'am.
So with the DHEA, if you're taking two doses, it would be better morning and early afternoon?
So the question is, with DHEA, would it be better morning and afternoon? Can I ask you this general thing? Is it twice daily dosing to get the amount in, or is it for a specific effect?
Just have to take twice a day.
Okay. So the comment was it was to take twice daily. Well, let me ask this general question then. Are there effects being experienced by DHEA taken in the afternoon?
Well, they're taking it at night, but
Okay.
but I'm not restless sleep already, so.
You already, okay. So the question is, would taking DHEA at night affect restless sleep? It can. It can. I think of it more as an uplifting. I kind of think of things energetically. So I would switch to taking it then, if you could, or the morning and afternoon. Again, I'm not supposed to treat an individual, just say generally. Yeah, your friend. Okay, your friend. Tell your friends switch to doing it that way and see. The other possibility is maybe considering the oral dose and a cream dose for a little bit different delivery system as well, or going to cream altogether. I know Dr. Wright does prefer cream dosing. Again, because we're bypassing the liver, that first pass effect. And so that may be a reason to switch. So, yes, ma'am.
Taking both your hormones at night, is the estrogen going to kind of have a potential to keep you awake?
So the question is, I've addressed this so many times with patients lately. It's pertinent that we're talking about it now. The question is, taking estrogen and progesterone at night, is it affecting sleep? I think that it can, but I don't know for sure. I have had a very few people take estrogen and progesterone at night and have it improve their sleep. One person did it accidentally. But if you have the ability to separate them, you have two separate applications. Try estrogen in the morning, progesterone at night. Here's why I like that delivery system. Because the estrogen in the morning, it generally, some people do have to dose twice a day, but generally it's taking care of symptoms during the day. And then the progesterone comes in and takes care of symptoms at night. So if there are problems with hot flashes, night sweats, incomplete reduction of symptoms, that may be a factor. I've had people, we get it separated, they cover the whole day, and suddenly the night sweats are gone. And so that may be, So the first thing I do when people are having problems with delivery, incomplete symptom relief, first, are they doing it morning and night? Second is, what's the application? Are you doing it to the skin, to the labia, other areas of the body? Generally, we're not very porous. You know, the rain does not go through. No matter how long we stand out there, we just get really wet. So basically, when you're applying a hormone, if you're going to apply it to the skin, you want to apply it to the most sensitive area possible, thin skin. But I've had people applying it to, let's say, the stomach or other places that are not very accepting. You can also get dermal fatigue. So applying there over and over, suddenly you'll get decreased effectiveness. The reason why things like the labia and the anal mucosa work, and think about it in terms of getting a cold, you know, we get a cold because the germs come in and they penetrate through the mucosa. Interestingly, women who get pap smears and someone in the room is sick, you can catch a cold through the vagina because it's mucosal. So you have to be careful with that. So the mucosal area is designed to be moist, to take things in. So that's why the application there is good. So I look at the application. Is it to the skin? Is it to the labia? How are you taking it in when I'm going to adjust dose? Before I just adjust the dose. And then if it looks good in the urine, but there are still symptoms, we might compare to the blood. So we do a track down to see where the problem is going on. Usually we get it. If breakthrough bleeding is continuing, in some women it does, what do we need to adjust then? Again, even though Suzanne Summers talks about liking to have periods, we don't recommend it because we don't really want it, the endometrial layer to always be, you know, built up and then sloughed off. After a while, that's not a good thing to have happen. Does that make sense? Okay. So those are some of the reasons why to use some of these particular hormones. And we do use progesterone in women who have had a hysterectomy because there are progesterone receptors throughout the body. I talked a lot about some of these things and why to take them. I want to address, though, DHEA and testosterone in women. I'll often wait a full month before starting someone on the androgens. And that's because exogenously, or outside of the body we don't tolerate it as well. And so women can have adverse effects. I wait to see whether estrogen and progesterone are good. We've got the right dose. And then we'll add in the androgens. DHEA, typically 5 to 15 milligrams, preferably in a cream if we can do it. Testosterone, and both DHEA and testosterone for libido. Here's the adverse effect that women see, and it's not fun when the androgens are too high. Women will come in and complain of hair loss. We don't like to lose hair on our head. Hair growth where we don't want it, on the lip, on the chin, other places on the body. I had one woman, she came in to see me, had not seen me before. She had been put on so much testosterone, she had muscle definition just like a guy's. She was on more than most men are given. So in women, it can cause irritability. I see too much testosterone cause aggression in men. But women don't get aggressive, we get irritable, right? The more polite. So, and acne. And no one appreciates getting acne, men or women. And so acne will develop when the androgens are let's say, given too soon in the treatment protocol, or given and not tolerated very well. So there are lots of reasons to do them, including libido, bone health, lots of reasons not to. And so it's a careful balance. And this is what I was saying earlier. Hair loss particularly, I've said many times, if I had the cure for hair loss, I'd be a very wealthy person right now. So, any questions on those types of things? By the way, men can see some of these problems too. Some of them are normal, but in terms of testosterone, you'll see it going down the pathway here, there, if you look at testosterone, it goes off to the left for DHT. So that pathway can lead to hair loss, BPH, other problems. And it's something we're refining more and more here in some of the testing, how to identify those men more at risk, and then certain products that actually push toward that particular pathway can actually also increase the risk of prostate cancer. So it's something we're continuing to refine. So I mentioned previously some benefits of estrogen. In particular, estriol it's one of the products we use extensively in Biest. It has it's anti-cancer. So it's not totally going to prevent cancer, but it has an anti-cancer component. That's why we use it. The other one we use quite a bit, even in women who are breast cancer survivors, is a product called 2-methoxyestradiol, which is the most anti-cancer estrogen that there is. So we will use that often in combination with 2-methoxyestradiol and estriol. Again, it has to be the right person, the right circumstances, relatively low risk. I mentioned urinary tract infections, dementia. Again, because of its ability to support the brain, support the, it reduces oxidative stress in the brain, helps reduce A beta and tau proteins, the things that accumulate in the brain. And so it's being used in terms of supporting people facing dementia and Alzheimer's disease. It does reduce vaginal dryness in women, vaginal atrophy, can help support libido. And then women will often experience postmenopausal arthritis. So I found estrogen can actually help improve those symptoms, the aches and pains that come with it. Yes, ma'am. So the comment is, Dr. Wright was mentioning using hormone creams on the face. What were they low percentages that he was talking about? Yeah. So yes, you can in fact use hormone creams on the face. I know Key Pharmacy, Custom Pharmacy, they'll often compound those for us depending on the use. I'm going to trust the master and say yes. So yeah,
I read that too, and it's just very, very.
They're very little.
Estriol, very
Yes,
low doses.
they're very little. I'd be the kind of a formulation like we might give for vaginal dryness or vaginal atrophy. Very, very tiny amount that is more topically applied for those that we give in terms of suppositories for vaginal atrophy. What we don't find a lot of penetration through the whole body. They act more locally. But if you think about it, what the benefit of estrogen is elasticity, tone, fullness, and so they are in very small amounts. You're not taking your entire hormone, dose on the face. Although people have used topical thyroid similarly, and that cream can often help with face issues. So applications through the skin, on the face, other places, a little bit different than we're talking about for systemic effect. The one area I don't like to suggest applying hormones is directly to the breast tissue. I've heard people doing that, but I don't like to recommend it since we're talking about lumps that can be estrogen receptor positive, progesterone receptor positive. So I don't like to deliver it there. I could be convinced otherwise, but I don't always think that's a good idea. So testosterone for men, many of the same benefits that women experience. Obviously, men also have estrogen and progesterone in smaller amounts. They even are susceptible for getting breast cancer. And so we want to watch in men the level of estrogen. We want at least 4 times the amount of testosterone as estrogen. And interestingly enough, I've had couples come in, and sometimes men have more estrogen than their wives who are in menopause. And so it has adverse effects in men. It can lead to gynecomastia, the breast enlargement. It can lead, if you think about how estrogen works, estrogen causes proliferation of cells. That's what it does in the uterus. It expands the endometrial lining. Well, in terms of the prostate, when we're looking at organs that are similar, it also can cause hyperplasia of the prostate, increasing symptoms of trouble with urination, enlargement of the prostate itself. But testosterone can actually help with that process, obviously bringing estrogen back down into the right levels. We also will use things like a product called Chrysin and Myomins. They help reduce estrogen. Had a lot of men recently coming in on some of the products designed to reduce estrogen in the body. There's one thing you've got to be careful of if you're using those, and that is in terms of this profile, and I know it's really hard to completely grasp it, there's an enzyme called 5-alpha reductase. So you don't want to take products that completely shut this off. Sometimes men will come in with that particular part of their test where everything is pushed all the way to the point that this pathway is blocked off. That can actually increase your risk of prostate cancer, for example. So you don't want to take things in extreme. Dr. Wright is fond of saying, women come in and want as little hormone as possible. Men want as much as possible. This is not derogatory. You actually have a lot more testosterone, and in terms of muscle definition strength, it's very important. Excuse me a second. So when I'm giving testosterone, I'm going to give it in doses of 75, 100 milligrams, depending on the individual. DHEA, I'm going to give in the doses of 20, 30, or even 50 milligrams, depending. So we are dosing higher. It's just that also we need to make sure that the doses are safe, that other factors are taken into account. Let's say like insulin resistance, that you aren't having a problem with blood sugar that can affect in how you process and use the testosterone. But low levels can also affect. Someone asked me earlier about testosterone. Low levels can slow wound healing. It can lead to poor concentration, memory lapses. But it is harder to detect in men. Unless they come in and actually ask me for a blood test or urine test, and that they're aware of these issues, it's really hard to tell. Whereas in women, it's, we have a clear definition most of the time in terms of age. Any questions? I'm coming to the end of this part. So any questions sort of before we bring it to a conclusion? Okay, so in terms of men, then it's important to test the free and total. Again, it's the free testosterone that's going to be most significant. That's the one that's available to the body. A lot of physicians out there fail to test that. So you want to make sure that you do test that. The same is true of the PSA. Earlier there was a question about testing for testosterone. When you're testing PSA, what you want to be sure to do is get it done by the same lab over and over. Different methods will give you different results. So in order to get a lab value that's relevant, have it done by the same method. Make sure that, for example, that insulin resistance is not a factor. Other metabolic issues are not factors in terms of absorption. And then measure estrogen levels as part of a 24-hour urine profile. The profile, as I said, measures everything on this particular list. And it would be explained to you by a physician who knows how to use this in such a way that it makes sense and can help reduce risk so that your doses remain in safe levels and that the metabolites are also what we would anticipate. I often will use the age management panel to tell me too about levels of testosterone, PSA, and inflammation factors. And we've talked a number of times about the benefits. Increased libido, that's often a key. People come in, both men and women. Stamina and strength, increased mood. It also, in terms of men, it helps with body composition, reduces fat levels, helps increase bone density. And because the heart's a muscle and testosterone works on muscle, it does help improve cardiovascular health to a point. If someone has severe cardiovascular disease, that's something to approach carefully. Now, questions, I think I addressed it earlier about prostate cancer. If it's present, if we know that it is there, then it's something I'm probably not going to address with giving testosterone. But if our testing shows it's not present, and that's why we test, then giving testosterone is not likely to contribute to or cause prostate cancer. So it's not going to increase that risk, at least according to studies and what others have said. Prostate cancer, just to put it in perspective, it's normally a very slow-growing cancer. By the time a man gets to be 90 or greater, the odds are close to 100% that prostate cancer will be there, but it is not a concern. Most men with prostate cancer do not die of it. There are some forms that are aggressive. They move a lot faster, and those are the ones to be concerned with. If it's a concern, let's say the high PSA, not a good prostate evaluation, there is a method I want to suggest that you can look into before you just run off and get a prostate surgery, basically, is consider color Doppler. There is a gentleman who comes to our clinic in the north who does color Doppler of prostate once every quarter. And that can actually identify whether there's a mass there or not, or whether there's high risk. So that's something to consider before getting a biopsy, prostatectomy, whatever. So it's not a given that just because there's, poor testing, that's something that means that you have prostate cancer. Yes, ma'am. The color, the color Doppler? Color, COLOR, and DOPPLER, color Doppler. And the gentleman who does it at the North Clinic is Dr. Tamburi. I don't know how to spell that. I think, excuse me a minute. The last two things I haven't discussed in great detail are pregnenolone and growth hormone. And I just want to say a few words about those. Pregnenolone is, if you recall, at the top of the list here, the master hormone. It goes everywhere. There is an indication for giving pregnenolone, and I will occasionally do this along with other hormones. And it helps with that thing, that word retrieval thing. Can't remember that word. What is that thing? It looks like this. What is this? Okay, yeah. Or why did I go in the kitchen? It helps with that type of memory retrieval. I'm not talking about someone moving into dementia, cognitive decline, Alzheimer's, but those types of word retrieval issues are normal. So pregnenolone has been known to help, and I've had patients come in and tell me they feel better on that. Small dosing, growth hormone, often get asked about that too, and in the studies show, mostly they've been done in men so far, they do show an advantage in terms of longevity and overall health, reducing risk from mortality of all causes. However, growth hormone is not one of those things that's in the market with price fluctuations reflecting it. It's being artificially kept up in price, and it's about $750 a month. Now, I have patients on lower amounts, around the $300, $350 mark. It's still very pricey. So there are things that can be done to help support growth hormone, including using amino acids, things like growth hormone pituitary support, amino acids like glutamine, ornithine, lysine, and arginine. So you can use those in order to help support growth hormone. Getting good levels of sleep, another way to support growth hormone. It's produced in the kidneys, so if growth hormone levels are low and there's a kidney issue, that's something to consider, improving kidney function. So I've covered these kind of quickly, kind of basically. Yes, ma'am.
How successful are the amino acids in raising growth hormone? Because if you,
I've seen them come up. I've
somewhat
seen people. I've seen them come up to normal. Here's the thing to know about growth hormone, though. It's one of the things where we get into the legalese of it. So if someone were interested, I would want to do a 24-hour urine. It's the only way actually to measure growth hormone effectively. It's not effective through blood. You get a 24-hour collection, you know your level. If it's low, then you are a candidate for growth hormone therapy. If you just want to raise it using the amino acid analogs, then you don't have to go through that kind of testing. But it can be worthwhile to know the numbers so you know if it's coming up. So I have seen it come up to better levels, but we're working on everything. Using zinc, testosterone, they also can help support growth hormone levels as well. So it's not the only thing to do. So I take that in context with what the individual wishes to do, what the goals are in terms of hormone therapy, and then we address that. But I have seen them come up. Not in everybody, and not everybody can take it, or it doesn't always agree with everyone, but I've seen it improve. So it's a lot cheaper than $750 a month.
What were the amino acids again, the glutamine and
Glutamine, ornithine, arginine, and I think I'm saying lysine, but I don't think I'm right on the fourth one. So, well, we're going to basically conclude the formal part of the